let's just think about it for a while and pose the question how the wound healing plays microbiology. There are two teams. We have a wound healing team which essentially depends on normal host with normal immune cells and adequate perfusion and oxygen delivery at the time of surgery. A key player here is the microcirculation, as you all know. And then we have a team of commensal bacteria. The commensal means the bacteria that belong to us, that reside on us, all over us. These bacteria are surface plants. They have very low capacity for invasion. They love surfaces and grow on these surfaces given a proper environment and nutrients. The mode they prefer to grow in is what is called a biofilm. And I understand that you will talk much more about the biofilm later. They stay on the surface, they don't penetrate, but they do destroy the wound healing if they are allowed to grow in that way. The key player here is time. It takes a while for the bacteria to establish themselves and start growing. In laboratory media, the multiplication time is half an hour. Inside the body, it can be several hours. And that's one of the reasons why the median time for discovering a wound infection is actually a week. It takes some time here. Now, it doesn't work. The wound itself, with normal healing capacity, is very resistant to bacteria. The tolerance is actually a concentration of 10 to the 5th of these commensal bacteria. Even in some circumstances, 10 to the 6th. It goes for Staphylococci, E. coli, whatever you have living on you. Behaves like this. But that takes normal wound healing capacity. And as we all know, we deal with smokers, those with diabetes, obesity, scarring, arteriosclerosis, organ failure, you name it. And all of these are detrimental to normal wound healing. So, any patient's lifestyle or disease or medication or certain behavior in the wound that impairs the microcirculation or the immune cells or oxygen delivery will diminish wound healing and invite bacterial growth. The tolerance will no longer be 10 to the 5th. It might even drop to 10 to 1 to create an infection. If you think about it, it's a difference of 10,000 times, sometimes even 100,000 times, between the perfect wound healing to resist bacteria and the damaged wound healing to resist bacteria. There are very few biological processes in our body that are working on this dimension of 10,000 to 100,000 times. So that's one reason why we need to consider wound healing all the time when we are dealing with antibiotic or any type of wound infection prophylaxis. Here is a list of established risk factors. The list could be much longer. You could replace it with other things that are also known to cause problems with infection. We can group these like this, and we can label these groups. So let's start with the top one. It is circumstances that damage circumstances associated with microvascular disease and disturb wound healing. Then in the middle we have a group of factors that we could easily label increased surgical trauma. And finally, surgery that really exceeded the patient's physiological reserves to tolerate that type of surgery. I'm a colorectal surgeon. I see quite a number of patients that have the problem of the bottom here. It's really a matter of when the local processes of the wound spills over to the systemic responses of the patient. if you look at these factors, you will say, where are the bacteria? Where is the hygienic aspects? They are lacking here. So we need to think a little about what has happened. There are three models for explaining surgical infections: a hygienic one, a surgery one, and a physiology one. Up to the end of 1980s, hygiene was the predominant explanation model. And in administrations of the government, it still is. But with the molecular biology that came around in the 1980s, end of 1980s, the situation changed completely. Very few of us ask about hygienic aspects to explain today. We are looking into how was the surgery done, and especially we are looking into what sort of patient are we actually offering this type of surgery to. Will that patient go through it? Will he take it? Will the wounds heal? So that's why physiology today is the important matter and what we need to consider. What's hygiene? Well, hygiene is essentially where are the bacteria? How do they land in the wound? How do we prevent it? And can we kill them? Antibiotic prophylaxis then belong to hygienic tradition. So let's say something about the antibiotics. A friend of mine, Moshe Schrein, released this little poem. And we know today that we are paying the price now of relentless antibiotic use. We need to think about it. Sweden is not as affected as some other parts of the world, but this is a growing problem, as we know. Let's move back a little more and see how it all started with Sir Ashley Miles in London, who was the professor of experimental pathology and director of Lister Institute. He came up in the 1930s and 40s with very interesting aspects of wound infection and wrote a very interesting book about it. Two young Americans, John Burke and Hiram Polk, were sent to London to learn from his techniques and his ideas. And they came up with the two basic papers that started it all with antibiotic prophylaxis. John Burke, The Mechanism of Antibiotic Prophylaxis in 1961, and Hiram Polk, the first randomized effective prophylaxis study in 1969. Both were based on the knowledge and methods that Ashley Miles had developed. So let's have a look what he actually did. He did this, very simple, very simple. He took 10 to the 5th dead or alive Staph aureus and injected those into the skin of a mouse. 24 hours later, he would find a little lesion 3 millimeters wide in those with dead Staph aureus and something like 12 millimeters wide in those with living Staph aureus. Then he gave antibiotics at the same time, 1 hour later, 2 hours later, 3 hours later, and 4 hours later. And this is what he found. When he gave antibiotics 4 hours after he had injected the bacteria, there was no effect of it any longer. John Burke took this information, had worked with it, and used it for demonstrating a basic principle of antibiotic prophylaxis. You have to give it first. Now, what did Polk do? Well, he did this randomized trial, and he came up with this information, which has been rather neglected, but is very important. On the x-axis, log wound bacteria. On the y-axis, surgical wound infection rate. If you look at the black bar, it's a dry wound without antibiotics, placebo. You can see for low doses of bacteria, 10 to the second, or low dose, low risk of infection, but as you come up to 10 to the fifth, you approach 50% infection rate. Move to the right, you add an antibiotic, and you can see you can have very high concentrations. Exactly, you restore the wound's capacity to resist bacterial loads. Move to the left, leave a hematoma in the wound, and you have the situation where very few bacteria will cause an infection. So these informations are from the 1960s, 50s, and 40s. Why don't we use them? Why are they not generally known among surgeons today? Because they are not. I bet you have never seen this before. So that's a pity, because here we have the basic circumstances that govern it all, whether we will succeed using antibiotics to avoid infection or not. So the pathogenesis of surgical infection, and this is a short form of course, the hematoma is a surgical infection incubator, when an antibiotic in the hematoma is a mechanism for prophylaxis. Early failed wound infection, wound healing will be secondarily infected. If the wound breaks down for other reasons than the bacteria, it will be infected. So let's see how people are actually using this in your field. This is from the recent systemic analysis that was published in PRS in January. And it's all about breast reconstruction and use of antibiotics. You will see that 90%, if you look at the bottom line here, 90% of the patients had antibiotic treatment for more than 24 hours, often until the drains were pulled, often a week, for no gain whatsoever. Here is the fool playing with 90% of the instances. And that is bad, of course. I cannot but support the fact that the game is over when you close the wound. And one dose of antibiotics does it all. That is the basic message. So, you should know the definitions that the C has defined for surgical site infections, superficial, deep, and organ space. But if you look at the list below, you will see a lot of signs of failed wound healing. And how can we decide whether it is infection or failed wound healing of some other sort? It's very difficult, and that will reflect in the registries. You will see infection rates of 1%, and you will see infection rates of 30%, depending how you rate those adverse observations. Any wound separation invites bacterial growth, and any growth of bacteria disrupts wound healing. So surgery must function in the world of bacteria, because bacteria have patience. It's their playground. That's where they live. And if we create surfaces through the skin into the patients, we are going to see some bacteria grow there. If we are clever, we can manage it. If we are less observant about the facts, we will fail at times. There is an apple of knowledge here. You can take it or resist it. But it takes a bit of reading, and this is a huge area of literature, unfortunately too big to understand really. Thank you.